You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, Assistant Professor of Medicine at Harvard Medical School and physician in the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts, and Oncology Medical Director of the Dana-Farber Brigham International Patient Center. Relevant disclosures can be found with the episode show notes on Medscape.com or on the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jacob Sands. Welcome to Season 3 of the Medscape In Discussion Lung Cancer Podcast Series. Today we'll discuss antibody-drug conjugates. But first, let me introduce my guest, Dr. Benjamin Levy. Dr. Levy is an associate professor at Johns Hopkins School of Medicine. Some of you may remember Dr. Levy was a guest on Season 1 of this podcast, where we discussed managing lung cancer with neoadjuvant and adjuvant therapy. Welcome to the Medscape In Discussion Lung Cancer Podcast, Dr. Levy.
Thanks for having me, Jacob, and thanks for having me back for another season.
So I've been very excited to have this discussion with you about antibody-drug conjugates. You've really discussed this quite a bit, including a wonderful discussion at ASCO with the ABCs of ADCs. In that, you do a great job of outlining the different components of antibody-drug conjugates and the importance of those. Can you give us that overview?
Yeah, just taking a step back, antibody-drug conjugates, they represent one of the fastest growing therapeutic drug classes in solid tumor oncology. We've got multiple different drugs that are now FDA approved for different solid tumor malignancies, and non-small cell lung cancer is no exception. The whole idea of antibody-drug conjugates is predicated on the three components of the compound. Essentially, you have a monoclonal antibody, usually an IgG1 in most contemporary ADCs. And that monoclonal antibody ideally wants to have high affinity and avidity for target antigen. You also want to have a long half-life. And then you, of course, have the target antigen. And I think we're still learning about what the optimal targeted antigen is, but you clearly want that antigen to be equally distributed and expressed on the tumor cell and absent expression in normal tissue so you can limit the toxicity of these drugs so these drugs can be more selective for the tumor. And then the two other components that are critical, one is the linker. Now, linkers are this component that link the warhead, the payload, which I'll talk about next, with that monoclonal antibody. Linkers can be either cleavable or non-cleavable. I would say that most contemporary ADCs utilize the non-cleavable linkers. That release of warhead from the monoclonal antibody doesn't necessarily have to happen in the lysosome the way it does for cleavable linkers. We can certainly talk more about that. And then the payload. The payloads are important. This is the warhead. This is the chemotherapeutic agent. And categorically, they are either microtubular inhibitors, DNA damaging agents, or topoisomerase inhibitors. And it's very complicated. And a lot of the generation of these drugs and how they're used is really predicated on sophisticated bioengineering and biochemistry. And I think we're still learning on how to optimize these drugs, conjugating better, more efficacious payloads, different types of monoclonal antibodies, which I'm sure we could talk about. But that's a 10,000-foot overview of these compounds. And if we had a conversation maybe 6 months from now, I may have a different conversation for you based on how quickly these classes of drugs are growing.
And you've done a great job previously of highlighting the different mechanisms of action from these antibody-drug conjugates. And so just briefly to state, you've described the three components, essentially an antibody binding specifically to antigen that's preferably in high concentration on tumor cells, pulling that antibody-drug conjugate in, releasing that warhead or the payload, the chemotherapy into the cells, leading to apoptosis. That payload, if it is membrane permeable, then having a bystander effect on surrounding cells. And the more complicated component is the potential immunotherapy efficacy. Can you just briefly highlight that third potential mechanism?
Yeah, we're still learning about it. And you bring up a good point that these drugs may be viewed through the lens of an immunotherapeutic class of drugs. This whole idea of antibody-dependent cellular cytotoxicity, you've got that FAB region of the monoclonal antibody binding to the target antigen on the tumor cell. But at that time of binding to the antigen on the cell surface, that FC portion of the monoclonal antibody, sort of the back end of the monoclonal antibody, can engage effector immune cells, bringing immune cells into the tumor or in close proximity to the tumor. It's also able to engage complement system pathways in the body. So yes, these drugs work by the bystander effect. Yes, they work by this natural way we think about them, by binding to the antigen, as you mentioned, Jacob. And then you've got this internalization of the antigen complex with the ADC and release of the payload. But also ADC plays a key role here, and it creates a foundation of some of these trials where we're looking at ADCs in combination with immunotherapy. Maybe there's synergy there that can be exploited that's rooted in scientific rationale that we just discussed.
Now, there are a lot of different antibody-drug conjugates that are currently in the clinic. In the lung cancer space, we're really starting to see this, but it's coming fast. So there are a lot of drugs to discuss. But for the purpose of this discussion, I'm going to focus it a little bit on TROP2, because we have two different drugs that on paper are the same. They're both TROP2-directed antibodies. Both of them with cleavable linkers, both of them with topoisomerase inhibitor payloads, yet we see some real differences in these drugs. So before we get to the discussion of those differences and how there's more to learn from that, let's start with discussing each of those drugs specifically. So Sacituzumab govitecan really being the first that was initially being studied in the lung space. That was kind of put on hold for development in other diseases. But now we're really seeing some of that data come out in lung. Can you give us an overview of Sacituzumab govitecan and some of the data that we're seeing now come out?
Yeah, I mean, I think just taking two steps back and TROP2 as a target, like why are we exploiting TROP2 as a protein and what are we seeing there? And we need to remember that TROP2 is a glycoprotein, a transmembrane glycoprotein. It is expressed on non-small cell lung cancer. And there is data that high expression of TROP2 correlates with worse outcome, being a poor prognostic biomarker or marker, which is one of the reasons that this pathway has been exploited with these drugs. The first TROP2 ADC that came about, as you mentioned, Jacob, was Sacituzumab govitecan. And the drug initially was looked at as far back as 2017 and 18 with a phase 1/2 study looking at Sacituzumab govitecan in a highly pretreated group of patients with non-small cell lung cancer. And the initial reports were modest activity. I mean, the objective response rate was somewhere in the order of 15 to 20%, PFS around 4 to 5 months, OS was 7 months. So this drug initially, had some modest activity in a cohort of roughly 50 non-small cell lung cancer patients who were highly pretreated. Some interesting things here that you mentioned. One was, and this will come up over and over again, that TROP2 overexpression didn't seem to predict response to this drug. And this will come up over and over again with the TROP2 exploits in non-small cell lung cancer. The second thing was toxicity, and that toxicity was mostly cytopenias, GI toxicity as well, so nausea, diarrhea specifically, and then the neutropenias and the febrile neutropenias. The drug has made some press release waves recently with a phase 3 study evaluating Sacituzumab govitecan versus docetaxel in second line for non-small cell lung cancer who have been initially treated with platinum immunotherapy. This is the EVOKE-01 data. Again, randomized phase 3 data comparing Sacituzumab govitecan versus docetaxel. And we got a press release in late January 2024, unfortunately showing that the drug did not meet the primary endpoint of the study of OS. We'll get more later. I think we'll get the nuances and the details and the subset analysis. But I think we're all surprised to hear this. I think we're disappointed. Whether this drug will make it in the second line, it's really, really unclear. Sacituzumab govitecan, like other TROP2 ADCs, has also been looked at in the front line, looking at small data sets in combination with pembrolizumab. Again, we talk about the synergy of potential ADCs with immunotherapy. The EVOKE-02 study looked at Sacituzumab govitecan plus pembrolizumab in two specific patient populations, a patient population TPS greater than 50%, a patient population with a TPS less than 50%. These were all treatment naive patients. So, abandoning the platinum altogether, abandoning pemetrexed altogether, and the doublet of ADC plus immunotherapy did show encouraging responses. Now we'll have to see how the data shakes out in larger trials, but encouraging data. Where this drug is going to land, I'm not real clear. I'm not sure. I mean, EVOKE-01, Again, docetaxel hanging on hard, tough to beat. We thought it would be easy to beat. It hasn't been easy to beat. So I'm curious to see how this drug unfolds into trials and to the clinical space for non-small cell lung cancer.
Before we talk more about that, just a comment on docetaxel. I think you'd be hard-pressed to find someone who ardently defends docetaxel. This is not a drug we're enthusiastic about using at this point, and I think that represents progress. I remember years ago, really, docetaxel was the second-line standard. It is now again. We then had the immunotherapy drugs step into the second line. So immunotherapy drugs beat docetaxel, and we were then using those second line. And it was exciting to then see positive results in the first line, of course, but then we were stuck again with docetaxel in the second line. And docetaxel in the second line now is a different experience than when we had a time frame of having another well-tolerated and potentially amazing drug in the second line setting. With immunotherapy, of course, we have a subset of patients that really have incredible durability to the drug. So now in the second line, docetaxel is even more so something that I think everyone would love to see a drug beat. That being said, when we have trials that are negative, where the drug does not beat in efficacy, I think the big thing that I would like to see more of is what about tolerability? And with docetaxel being such a challenging drug for so many patients, tolerability is an advance in itself. And certainly, we shouldn't be advancing drugs just based on some consideration of tolerability unless it's really extraordinary, but there should be an expectation for beating in efficacy as well. But when we see the final data come out, what is the real improvement to someone's quality of life? And I think a lot of times I see drugs just kind of getting written off or trials getting written off as saying, oh, it was a negative trial and therefore wipe it away. I think that's relevant in the small cell lung cancer space as well, which of course we've discussed in other venues. So Sacituzumab govitecan, TROP2 antibody-drug conjugate, topoisomerase payload. Let's talk about another drug that on paper looks the same. Topoisomerase inhibitor payload, TROP2 ADC, cleavable linker, Datopotamab deruxtecan. We've seen a second-line trial in TROPION-Lung01 that was versus docetaxel as well. And so can you take us through that top line and overview of what we saw in that trial?
Yeah, it's the analog to the Sacituzumab EVOKE-1, the TROPION-Lung01 with a different drug. Very similar on paper. Datopotamab deruxtecan, the monoclonal antibody, the linker with the topoisomerase 1 payload. The DAR is a little different. It's a little less than Sacituzumab govitecan. It's 4. I think Sacituzumab govitecan, the DAR is 8.
Well, wait, before you go on, actually, just to say the DAR, so the drug to antibody ratio, give a quick overview on that because we kind of skipped by that, I think, in the first part.
Yeah, really important. DAR, essentially, to be as high level as possible, is just the amount of payload moieties attached to the monoclonal antibody. And you kind of want that sweet spot of a high DAR, but the higher you go, the more toxicity you have. So you want that sweet spot of a DAR at a level that achieves efficacy for a patient, but doesn't disrupt or add to toxicity. And this is always the question of what is the optimal DAR? Counterintuitively also, the higher the DAR, it seems like that may also enhance drug clearance by the liver, which makes it less efficacious. So we're just learning about DAR, like we're learning about many components of this construct, this ADC construct. So yeah, there's a bit of a difference in the DAR between Sacituzumab govitecan with a DAR of 8 and Datopotamab deruxtecan with a DAR of 4. So leaning into the TROPION-Lung01, very similar design. Phase 3 study comparing Datopotamab deruxtecan versus docetaxel. In this study, there were patients that had actionable genomic alterations who could have received a targeted therapy and then followed by chemotherapy and immunotherapy, or those without actionable mutations who got just chemo IO. So this was essentially second line or third line comparison between Dato-DXd, Datopotamab deruxtecan, versus docetaxel. There were some stratification factors with histology, having an actionable alteration or not. I think those were the two most important things. This data, Jacob, you and I were both there when this data was presented at ESMO in Madrid just in October. We don't have the full publication yet. Bottom line was we saw an improvement in progression-free survival for patients who got Datopotamab deruxtecan versus docetaxel. Hazard ratio about 0.75. A small benefit in medians in PFS, around 4 weeks. And If we looked at the breakdown of histology, interestingly, this was an interesting signal that it seemed like the benefit was really restricted to the non-squamous patient population, where actually patients with squamous histology did better with docetaxel than they did with Datopotamab deruxtecan. It'll be interesting to see how this EVOKE-1 with Sacituzumab govitecan, where that histology interaction is and what that looks like. We don't know that yet. When we looked at the OS curves for the study, there was a trend towards overall survival. Once again, if you broke it out by histology, it seems like that trend is restricted to the non-squamous patient population. When we start talking about these drugs, you can't just talk about efficacy. You raise a good point about quality of life and tolerability. Got to mention the toxicity here, little different than Sacituzumab govitecan. We saw this signal of stomatitis that we've seen many times when this drug has been presented. And it's interesting because, as you mentioned, Jacob, Sacituzumab govitecan, also Trop-2 ADC, doesn't have an adverse event signal with stomatitis. So, this is something that does occur quite frequently. It was one of the most common, frequent treatment-related adverse events from the study. We're learning on how to mitigate it. And again, we don't have approval here yet. We've got a modest benefit in PFS, and we've got a trend towards OS. I think we will learn in the next 2 to 3 months whether this trial shows an OS or not. But again, the challenge here is that docetaxel is so difficult to give. Do we also need to consider the toxicity profiles as well? Now, I'll say that I've used a lot of this drug, and the challenge here is the stomatitis, and the challenge is some of the other toxicities GI related. But as a whole, I think this drug is better tolerated than docetaxel in my anecdotal experience. And we saw this from the trial, actually, that there were more dose reductions with docetaxel. There was more dose discontinuations with docetaxel. So I think as a whole, this drug was better tolerated than docetaxel. And that's what we're looking for. We're looking for a drug that outperforms docetaxel that's also better tolerated.
So you highlighted histology, and I think this now really comes to the center of the Datopotamab deruxtecan story. Of course, detrimental, it seems, in squamous. Docetaxel seems to beat Dato-DXd in squame. But in non-squame, we saw about a 2-month improvement in median progression-free survival, and that's 3.7 months to 5.6 months. So by percentage-wise, that's also quite a big jump, as well as an improvement in overall response rate from about 13% with docetaxel to 31% with Dato-DXd. So you're right, the intent to treat population, about a 3 to 4 week improvement in median PFS, but really hampered by squamous, which I think we'd say certainly not use the drug in squamous, it seems. But in non-squamous, I think a pretty meaningful improvement in the median progression-free survival. And as you highlighted, actually with the non-squamous group, I'd say the trend in overall survival looks encouraging. The overall survival for the intent to treat, this is obviously going to be hampered by the squamous subgroup, which now it seems is not relevant in further advancing this trial.
You bring up a great point. I failed to mention a couple of things I want to say to just add on to this narrative on Trop-2 ADCs and non-small cell lung cancer. One, if you look at the response rates for TROPION-Lung01, there was a doubling of the response rate with Dato-DXd versus docetaxel. That's really important. Many of our patients who have disease progression on chemo IO do benefit from robust responses and meaningful responses. And it seemed like, again, there were more responses, doubling of that in the docetaxel arm when looking at the Dato-DXd arm. The second thing I want to say is going back to the enrichment strategies of the biomarkers. These are Trop-2 ADCs, and one would think by the way these drugs work that overexpression of the antigen, which the ADC is targeting, would predict better outcomes with these drugs. But we've seen from the Sacituzumab govitecan story, the phase 1/2 effort, we've seen from TROPION-Lung01, we've seen from other studies that Trop-2 expression really doesn't matter. And at least Trop-2 the way it's measured now. So with the biomarker search is really needed here. We really have a lot of work, and there is exquisite complexity with, number one, how these drugs are constructed, and number two, how they act mechanistically at the level of the tumor and the tumor microenvironment. So we're just at the ground floor here.
Now that leads us into the most perplexing part to me, which is the toxicity profile. So with Sacituzumab govitecan, we see a lot of diarrhea. We see cytopenias. We see really what looks like typical chemotherapy types of toxicities. I think irinotecan certainly would be the one that we'd point to most. The dosing with day 1, day 8 out of 21 is also a difference with the Saci versus the Dato, which is once every 3 weeks. The diarrhea, there are some, it's a small numbers, but really acute diarrhea where atropine is given in the infusion room. That's not common, but that can come up, which I think is a unique tox dimension, but more commonly in the days after and, for a few days after. So something that's manageable, certainly wouldn't overstate this, where Imodium would be a way to treat. And I think in many cases, very manageable, but a profile that people are pretty familiar with because it looks like chemotherapy. Now, Dato-DXd does not have nearly as much of those kinds of toxicities, but have these unique ones, stomatitis, eye surface toxicity. We see those types of things in other chemo agents. I think the eye surface toxicity feels similar to what I see with pemetrexed. I'm not sure that the mechanism is the same, and I think there's a lot more to learn. But as far as the management with artificial tears and such, and then of course there's ILD, which has also been reported with Dato-DXd. What do you make of the two drugs that on paper look the same, except for, as you've highlighted, the DAR, there being a little bit of a difference in those, but having such a different toxicity profile on top of what looks like efficacy differences that are maybe more subtle?
Your question is a great one and sort of underscores and highlights the idea, put simply, that we have really very little understanding of how these drugs work. And we're just learning about these differences in toxicity. I mean, adding on to that question is, why did these drugs cause ILD? I mean, we can talk about that, but, we saw some ILD, adjudicated ILD, interstitial lung disease with these drugs. And I think we're learning how that happens. And how does keratopathies happen with some of these compounds? I don't think we really know why one drug that looks just like another drug on paper have these differences in side effects. And it'll be interesting to see how the next iteration and permutations of these TROP2 ADCs, what side effects are going to be there. But I don't have a great answer for you in terms of why we're seeing this. I think we need to learn more on how these drugs truly work at the level of the tumor and tumor microenvironment, off-target toxicities. I struggle with this. I really do. I think perhaps you've raised this. More importantly is what's best for the patient, right? What are patients going to be able to better tolerate? Is it going to be GI toxicities and neutropenia a la Sacituzumab govitecan, or is it going to be the stomatitis that we see with Datopotamab deruxtecan? Are we going to have really good mitigation strategies for stomatitis? These are all great questions and really underscore this whole idea that we're at the ground floor here. I was just reading a review article on ADCs that just came out, and I learned something new that I didn't know from the last review article, because there's been new data that's come out that just kind of better explains what's happening here. All of this is going to be helped by, I hate to say this because this is what we all say, a lot of the translational efforts from these future trials, looking at tissue and blood, looking at distribution somehow of internalization of ADC. There are ongoing works looking at this, and we'll just have to see how the data pans out.
So just to highlight a couple things from that discussion, because it's a long one. With these TROP2 ADCs, I think there's some really promising data. It is exciting to see what looks like a real efficacy signal, at least within the median progression-free survival for non-squamous non-small cell lung cancer with Dato-DXd. We're still awaiting the full data on Saci, and to have an overall negative for median overall survival obviously is such a small slice of the story on that. I look forward to really seeing the details. But this is a class where we've seen booming. And so we've focused a lot of our discussion on TROP2. So just briefly to highlight the fact that this really is something where there are multiple other drugs. Trastuzumab deruxtecan, this is an FDA-approved drug for HER2 mutant non-small cell lung cancer. And I really highlight that specifically because we're used to seeing in breast with HER2 expression. In lung cancer, it's HER2 mutant. And the dose is a little bit less. It's slightly different. So I'll just highlight that. For the sake of time, I'm going to breeze past trastuzumab deruxtecan, though, even though I'd really ask our listeners to go and look at that specifically and be aware of that as a drug that is FDA approved. Are there other ADCs that you would specifically highlight right now?
Yeah, I think keep your eye on Sacituzumab vedotin. This is a MET-directed ADC, and we've had data both in EGFR wild type and EGFR mutant data set showing that this drug may be active, and that in this case may be c-MET overexpression makes a difference, which is very different than the overexpression with TROP2 and others that doesn't seem to predict response to drugs. So I would keep your eye on that. I would have said keep your eye on Toxicity riptansine, the CEACAM5 ADC, but that drug, unfortunately, we just found out is a negative trial compared to docetaxel in an enriched patient population. The thing I would say maybe instead of looking at specific drugs, and I do think Sacituzumab vedotin is sort of next to see where this heads, but looking at sort of these future perspectives of ADCs, these bispecific ADCs, the dual payload ADCs, these barotropic ADCs, where these monoclonal antibodies bind to one antigen, but different epitopes within the same antigen, ADCs with immune stimulating payloads, radionucleotide ADCs. This is where I think we're going to see real activity. We're going to have to think about how this stacks up with toxicities as well. But I think we're at the beta version of these drugs. And I think these new compounds and classes of compounds, that the future is much brighter for the ADCs. And we'll have to see how it all pans out.
I think a lot of what we've been discussing are drugs with payloads of chemotherapy. And I think one of the most exciting things to me in this is that we're seeing a proof of concept of antibody-drug conjugates as a therapeutic. And I look forward to next generations that will inevitably have other components. And we're talking about payload with chemo, but of course there are other potential things that can be added. What would you speculate in 10 years when we do this again? Let's say 5 years, 10's impossible to say. In 5 years when we look ahead, what are the types of things that you think will be on these, or what do you anticipate as the next generations?
I'll mention one class that I'm excited about only because we've had preliminary data that's come out with some of these compounds. But these bispecific ADCs, or these bispecific ADCs that have dual payloads, to me, I mean, this is where we need to get better with our payloads. There have been some in this field who feel that the reason we're not seeing the efficacy that we would thought we would see with some of these drugs has everything to do with the payload. And it's complicated. I mean, this is all about synthetic biochemistry, how you conjugate a particular payload moiety to the monoclonal antibody. I mean, it is exceptionally complicated how these drugs are crafted and generated. But in my mind, we've had some preliminary data on these bispecific ADCs with either the same payload or dual payloads that are showing exquisite activity, specifically in EGFR mutant lung cancer. So I think that's probably 5 years. I think 10 years, we are looking at these ADCs with immune stimulating payloads like the TLR8 agonist that essentially, yes, we start to view these drugs as really through the prism of an immunotherapeutic approach, where these immune stimulating payloads really can truly engage the effector arm of the immune system and bring that in. And maybe this capitalizes by looking at them in a synergistic way with immunotherapy. We'll see.
Well, there's obviously a lot to talk about with antibody-drug conjugates, but unfortunately, that's all the time we have today. Today, we talked to Dr. Benjamin Levy. I want to thank you, the listener, for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on lung cancer. This is Dr. Jacob Sands for the Medscape In Discussion Lung Cancer Podcast.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on lung cancer.